delighted to welcome you to this interactive and hopefully discussion-oriented lunch on LITT, laser interstitial thermal therapy, and indications, uses, experience in CNS oncology. I'm Roy Strowd, one of the neuro-oncologists at Wake Forest, and joined by two tremendous colleagues to help guide us through a interactive discussion. First, you're going to hear from Dr. John de Groot. This group, I hope, knows him well. He is professor in the Department of Neurosurgery at UCSF, has a long career as a tremendous educator as well as clinical trialist, and will begin the discussion with uses and thoughts, overview of LITT and its uses in glioma. So that's where we'll start this discussion. I will jump back up here for part two, which will discuss LITT for radiation necrosis and give you an idea of kind of how this fits into the neuro-oncology toolbox to manage radiation necrosis. And then the third talk to bring us home will be Dr. Peter Fecci, professor of neurosurgery at Duke University, sort of extraordinaire when it comes to LITT, and he will bring both data and his thoughts and experience on the uses of LITT for brain metastasis. That difficult situation of, is it a brain met, is it radiation necrosis, where does LITT fit in, and talk about the Remaster study to address important ongoing questions when it comes to LITT. We hope this is very interactive and discussion-oriented, so if you have questions, throw up a hand or shout it out, and we're happy to engage as we go through this. There will be opportunity for questions at the end of each talk. And maybe just before we get started, as a show of hands, just to see who's here, a little bit of a straw poll. How many are neuro-oncologists or medical oncologists who are here? Great. And how about neurosurgeons? Good. You're outnumbering all the rest of us. That's great. Radiation oncologists? Any radiation oncologists? Excellent. And any allied health or other? Great. Well, we hope to hit each specialty area. And actually, just as a last group, any trainees, students, residents, fellows? Fantastic. So we hope to hit each group. We have a diverse audience here, and please ask questions as we go through. Dr. de Groot.
Thanks for the opportunity to talk to you today a little bit about LITT in glioma, primary brain tumors, and really excited to share some of our recent data. These are my disclosures, and I serve as the consultant for Monteris, importantly. So this is an outline of sort of what I will be talking about, just talking about general applications, kind of an overview of what is LITT. I think all the surgeons in the room probably know what that is. And then talk a little bit about the clinical data review for the recent work that we did in IDH wild-type glioblastoma. We can talk a little bit about the future, sort of where is the field going, sort of beyond cytoreduction, and in that context, talk about some of the ongoing clinical trials. So as everyone probably knows, LITT would be, sort of tumor agnostic. You can use it for any tumor type, and it has been used for many, whether it's high grade, low grade, metastases, radiation necrosis. So there's a potential benefit for all of those different types of indications. But we also think about, the patient and, frail patients who maybe aren't great surgical candidates. We would consider using LITT for radiation necrosis, patients who might be steroid dependent, and as a way of treating the necrosis and getting them off of steroids. Poor KPS, or patients who are maybe either unwilling or unable to tolerate a regular craniotomy. So those are some of the main indications that we think about. We have a couple of new recent endorsements. I think this is really fantastic. They're not level one, but this is, I think, the first step in getting to there. The NCCN has endorsed LITT for primary brain tumors, for radiation necrosis, and for brain metastases. And then the CNS LAANS guidelines has reported also their support for use in multiple indications in oncology. So it's very exciting and the first step to getting level one evidence there. So what is LITT? And as I mentioned, this is something the surgeons are very familiar with. So it's sort of the same approach you would take with a stereotactic biopsy through a burr hole. In fact, probably most surgeons would take a biopsy at the time of LITT, and that's really important to help guide the therapy. This is usually done in an MR suite with thermography. For smaller lesions, usually 4 centimeters or smaller. And then after the procedure, it's a very quick closure, and then usually pretty rapid discharge from the hospital in a day or so. In terms of the NeuroBlade system, it uses MR thermography and uses the phase change from the MRI in 3 planes to determine the sort of real-time temperature data. This is sort of a standard that's been established for several decades now. The cumulative equivalent minutes at 43 degrees C is sort of the determination of the dose and the duration, which then impacts what happens to the tissue. So the longer duration of treatment, the more death there is to tissue. And then there's usually also a penumbra around where there's sort of more recoverable areas, and that's sort of the area where we also see a fair amount of edema and breakdown of the blood-brain barrier. So in terms of the clinical review, I think just the first sort of major comment really is that LITT is very safe. This is a table on the far left is all of the data from thousands of patients who have had LITT for a brain tumor indication. The center column here is for LITT for patients who've had LITT for epilepsy. And then the far right is sort of more like this historical control for more outcomes and adverse events related to more traditional craniotomy. And really, there's nothing that really stands out as being worrisome in the LITT subgroups. There might be a little bit more cerebral edema in patients with LITT undergoing brain tumors. Not that surprising, given the fact that these tumors are usually very vascular and have a lot of vascular permeability. But there's no sort of safety concerns with LITT for any of these indications. So I want to switch gears a little bit and talk about sort of where we went in terms of the glioma studies. So Monteris has sponsored a prospective multi-center kind of real-world data registry. It's called LAANTERN, which stands for, I always have to read this, Laser Ablation of Abnormal Neurologic Tissue Using Robotic NeuroBlade. And this has been really key to getting information about patients in the real world who are getting LITT for really any indication, glioma, METs, radiation necrosis, or other. The study objectives are primarily to sort of record safety, a lot of the data that you just saw on the previous slide, and to look at outcomes, local control, progression-free survival, overall survival, and also there's an effort looking at quality of life. So the data is collected, there's a very rigorous data management, event adjudication, the images are being collected and analyzed, again, for things like extent of resection and future other possible outcomes. And so a lot of the published literature now comes from the data collected under LAANTERN. So it's been really a key critical component of what we understand about the benefits of LITT in this patient population. There's also multiple ongoing efforts in addition to those publications that you see as listed on the left there. So these are the sites currently enrolling on the registry. There's, I think, some centers that are much more active than others, but it's sort of a nationwide effort, and so we're getting really good data from lots of centers of excellence. So a lot of the published data up to more recently has been looking at sort of cohorts of patients that are mixed. So newly diagnosed and recurrent, throwing in some other tumor types, meningiomas, high grade and low grade, and sometimes the publications are sort of lumping the outcomes from all of those different patient subtypes. And so it's been really hard for us to see just how effective is this therapy in sort of our bread and butter, GBM, IDH wild type. And so we really wanted to look very, very diligently at this group. And so we went into the registry and pulled out just those that are IDH wild type, GBM. We selected any KPS adults and with a couple years of follow-up. And our intent here was to have the largest sort of experience that we could glean the best sort of outcomes data. And so we collected data from 14 centers from January 2016 to May of 2019, and again, looking at overall survival, PFS, and then procedural related outcomes. And this is the consort diagram from this. I just want to spend a couple seconds on this. Oh, ooh, wow, it's small. So there were about 117 patients in the registry. We excluded the IDH mutant tumors sort of off the bat. But then we had a cohort of patients that were sort of IDH unknown, so that just wasn't collected or wasn't recorded in the registry. And so in order to try and increase our numbers, what we decided to do was to take any of those IDH unknown and take patients who were older than 55, where the incidence of IDH mutation is exceedingly low, like it's less than 1% in that patient cohort. So that helped us to add another 11 or 12 patients onto that cohort. So we think this is a pretty a good IDH wild type cohort of patients in this group. And so we had 89 total, 60 recurrent, and 29 newly diagnosed, with pretty typical, age and gender distributions and baseline KPS. KPS was a little worse, a little lower in the newly diagnosed, and in the recurrent disease, the tumor volumes were a little higher, but a pretty good consistent group across both cohorts. What was also asked in the registry is sort of what is the indication, what was the reason for choosing LITT for that particular patient. Most patients, it was sort of a non-resectable lesion, so that's kind of where we think about LITT having a major impact. But what's surprising is in both groups, newly diagnosed and recurrent, 40% of patients, it was reported that a minimally invasive procedure was preferred. And we don't know exactly who preferred that, whether it was the patient or the surgeon, or that was a conversation that they had that led to that. But I think this is a kind of an important thing as we think about and talk to patients about LITT and its potential benefits. In terms of procedural outcomes, outcomes were, in terms of safety, were pretty minimal. There was about a 13.5% device procedure-related adverse events. Most of these were transient, cerebral edema-related, and resolved within 30 days. And as we mentioned, one of the benefits, of course, of the procedure is sort of relatively quick discharge from the hospital, and so the median length of stay for this cohort was 50 hours. In terms of the outcomes, if you look across the recurrent disease, the time from diagnosis to death was 27 months, which is pretty long. So it is possible that this cohort of patients was doing pretty well. But from the time of the procedure to death was about 9 months, which is right in line with what you see with standard of care. It's in line with what you see for most clinical trials. So I think this is really good evidence that this approach is effective. In the newly diagnosed, we had a bit of a surprise because the time from diagnosis to death was around 9.5 months, which is pretty short. And so what we did is we dug a little deeper into the data, and what we found was that a lot of those patients didn't actually get treated or didn't get standard of care after the procedure. And so when you look at the cohort of patients who did get chemoradiation, as you would expect, the median survival looked very consistent with what you see with standard of care after craniotomy. So I think there's a lot of really important points and things to kind of delve into as we think about it. And these are the Kaplan-Meier curves for newly diagnosed and recurrent. Again, 40% at 12 months, and then 60% at 2 years, which is really, I think, very strong data. So again, switching gears, we always think about LITT in terms of extent of ablation, cytoreduction, but there are also other potential benefits. And there are two key ones that we think about, that we might know about. There's probably others that we don't know about. One of them is breakdown of the blood-brain barrier, which can help with drug delivery, for example. And then the other is its impact on the immune system. And so ablation can really release new antigens. It can disrupt the barrier. It can help attract immune cells into the tumor microenvironment. And there may be other impacts of hyperthermia on. This is some of the data from Eric Luthart's group looking at blood-brain barrier, blood-brain tumor barrier, and showing that LITT induces increase in vascular permeability, which can last for upwards of 4 weeks. And in some preclinical models, able to demonstrate sort of synergy with chemotherapy and greater delivery of chemotherapy and improvement in animal survival, as you can see in this study here. And then in terms of the combination with checkpoint inhibition, this is the data from SNOW from a year ago. Again, Eric Luthart's group, Jane Champion was the first author on that study, showing that LITT with Pembro led to longer overall survival compared to Pembro alone, sort of a doubling there, as you can see. And then if you compare it to historic LITT controls, Pembro plus LITT looks a little better than just LITT alone, and then certainly a little bit better than standard chemotherapy. Again, historical controls for comparison there. So I think there's a lot of excitement. I know I certainly am, and we have some really interesting ideas in terms of how to integrate LITT with chemotherapy, but also LITT with immunotherapy. And you can see here there's multiple trials with LITT and chemoradiation, or LITT with checkpoint inhibition. And as Peter said, hopefully there'll be some papers published in that arena soon. So with that, just kind of summarize quickly, very strong safety, and I think really great efficacy data from non-randomized trials. There's a growing body of evidence for glioma, but also for recurrent brain mets, which you'll hear about from Dr. Fecci soon. And then LITT's a great tool. Obviously, if a patient's going for a biopsy, they can get LITT afterwards, again, depending on what's seen at the time of biopsy. Great hospitalization data, very low rates of side effects and device-related permanent adverse events, and a real opportunity to use this as a tool, particularly I think for patients that aren't trial eligible, patients with deep-seated tumors, poor KPS, and the other indications that we mentioned. So. Thank you very much for listening, and I'll pass it on to Roy Strowd.
But in the second part, I'm going to turn to radiation necrosis. And at Wake Forest, our surgeons did their first laser in 2010, and these were a lot of our initial discussions in the first few years, LITT for gliomas, that there was a sort of a second epoch of LITT is potentially a valuable option for patients with recurrent brain mets before or after stereotactic radiosurgery. And I think recently a lot of our discussions, at least from the neuro-oncology side, are patients with radiation necrosis, late radiation necrosis after treatment, as well as recurrent glioma patients. So in the second part of the talk, I wanted to turn to radiation necrosis and think in greater detail about where LITT fits into the toolbox, at least from the neuro-oncology side. In terms of disclosures listed here. So again, we're going to move to the far right side of the screen. Dr. Groot gave us a good overview, talked about gliomas. In Dr. Fecci's talk, we'll talk more about brain metastasis, but wanted to sit in this kind of right side of the space here. How do we think about LITT in terms of radiation necrosis, particularly from the standpoint and viewpoint of a neuro-oncologist? And wanted to start initially with pathophysiology, and this may be a bad place to start because in terms of LITT and what it's doing in a lesion of radiation necrosis, that is unclear. But in terms of radiation necrosis, as this group well knows, the underlying pathophysiology is really thought to initiate with vascular injury. release of hypoxia-inducible factors which drive VEGF expression, and this has really led to the frequent clinical use of bevacizumab for these patients. But there are a number of feed-forward pathways, cytokine release and chemotactic factors that also contribute to downstream inflammation, which is really where steroids are working. And where I hope to go with this part of the talk is we use steroids. They're first-line treatment for radiation necrosis, but are often ineffective and many patients recur. Clinically, we see a lot of use of bevacizumab, which is acting on one specific part of this pathway, but LITT is really molecularly agnostic and acts potentially well upstream of this at that initial vascular injury and could have a rational role in the use of treating patients with radiation necrosis. When we think about imaging changes for this patient population, we think about pseudo-response, pseudo-progression, radiation necrosis, and we like to define these with clearly described time points, pseudo-progression being a transient early endothelial injury process in that first 1 to 6 months following radiation, and radiation necrosis being a frank disease occurring late. But we know that this is really a continuum and a spectrum of what's happening pathophysiologically. I do think it's helpful to think a little bit more about what is happening and when we can intervene and what we should use at those time points. In the first 0 to 2 months following radiation, we really see a process that's driven by vascular injury, release of the HIFs, upregulation of circulating VEGF, and that's what's driving this pseudo-progression that we see on imaging in patients. In that 2 to 6 month period of time, we begin to see glial-mediated injury, direct damage to oligodendrocytes. And then out at 6 months, it's very multifactorial with activation of the immune system, inflammatory mediators infiltrating into this lesion. And at this point, we have a disease that will beget further disease if not intervened. And so as we're thinking about what's the right place and timing for steroids, for bevacizumab, or potentially LITT, the timing of this process can be helpful in selecting an optimal treatment. So I'm going to very briefly and quickly run through typical management of radiation necrosis. None of this will be a surprise to this group, but I think it is helpful to think about what is in our toolbox and what data supports that. Initially, it is important to say and state and remind ourselves of the importance of biopsy. And obtaining tissue in patients with suspected radiation necrosis is critical. As this group well knows, symptoms overlap in terms of presentations of both radiation necrosis and tumor progression, misdiagnosis either of tumor, of what is really radiation necrosis, or radiation necrosis of what is really tumor is harmful for patients on both directions. And it's very difficult, as this group knows, to use MRI findings alone. So what are our treatments for radiation necrosis? Asymptomatic patients we often monitor with serial scans, and I'm going to focus on steroids, bev, surgery, and then where does laser fit into that armamentarium. In terms of steroids, we often think about this first, it's the gold standard, but really doesn't treat the underlying disease process. And as we will see, and you all certainly experience in your clinical practice, many failures to initial steroid treatment of radiation necrosis. We also worry about the side effects, diabetes, weight gain, myopathy, psychosis, things that you all are familiar with. This is the first paper I wanted to discuss, a nice study, a prospective randomized study of patients treated with bev versus steroids for radiation necrosis. And we can see here data that supports the use of bev, which I think we see increasingly clinically. 51% of patients with improvement in flare, 25% with improvement in enhancement with bevacizumab, compared to around 20% or 5% with corticosteroids. We often use steroids quickly and early in these patients, but bev certainly is superior in terms of imaging response and has led to a number of studies, or at least one study, looking at this prospectively. So if that's steroids, where does bev fit into the picture? I think this group well knows bevacizumab is recombinant humanized monoclonal antibody to circulating VEGF ligand. No impact on survival in terms of treating tumor, and a number of potentially rare side effects as well as things that we more commonly see, headache, fatigue, proteinuria, hypertension. There's no prospective data to support the use of bev for radiation necrosis. And this is about the best study that we have, a meta-analysis of 12 studies, 89 patients, demonstrating 93% radiographic improvement in both the contrast enhancement and flare. And importantly, the reason we use this clinically in neuro-oncology is 10% of patients with stable symptoms, 46% with improvement in symptoms, and 40% complete resolution, and discontinuation of DEX in 97% of patients. But importantly, in the studies that have looked at this, recurrence rate is high. And at least in my practice, we usually treat with 5 mg per kg, 4 doses, and 8 months, 9 months, 10 months later, that's when we can see recurrence at least in studies up to 77% of the time. So currently, there is no level 1 evidence for the use of BEV for radiation necrosis. And the study that was going to answer this question, the Alliance BEST study, steroids plus BEV versus steroids alone for radiation necrosis, wasn't the best study. It was limited in its accrual and was unable to be completed, really because of a lack of equipoise around this clinical question. Surgery is the gold standard for managing radiation necrosis for a number of reasons, but clinically we struggle with recommending surgery for these patients as a result of the potential for morbidity. And so this has really invited a discussion of where should we fit LITT into the toolbox for managing radiation necrosis. And I won't go through these sort of introductory comments which you've heard from Dr. Groot, but we'll review the data supporting decreases in steroid independence and where LITT stands in terms of guideline-based recommendations. And I want to pause just a minute on this slide. It is important. So if you look at the NCCN guidelines, laser therapy is considered a surgical alternative for patients who are unable to undergo surgical resection for brain metastasis radiation necrosis, and just recently, in the most recent version of the NCCN guidelines, recurrent glioblastoma. And I put this up here not because you aren't aware of this or won't be at the end of these talks, but this is really helpful when we're working with insurance companies to justify payment for this treatment. So where should we think about LITT in terms of management of radiation necrosis? How does it compare with steroids and with bevacizumab? This is a study that Dr. Fecci will also touch on, a study by his group, which he has generously allowed me to summarize some of the important data from this study. And I'll let him talk through the graph. This was a retrospective review, 81 patients, 57 treated with LITT, 15 with maximal medical management, which was really steroids. And the take-home here is patients that were treated with LITT were 3 times more likely to be weaned from steroids. So you can see here in the table, 84% of patients in the LITT arm were able to be weaned from steroids compared to 53% in the steroid arm. And initially, when we were doing this at Wake, the concern was cerebral edema after the LITT therapy. So we're treating radiation necrosis, we're causing edema with LITT, and patients would be on steroids for a longer period of time. And we see exactly the opposite. Not only do patients reduce their steroid dose, but many of them are able to wean completely. What about BEV versus LITT for radiation necrosis? There's 2 studies that I will point at. There's no upfront prospective data that compares this, and so we're left with retrospective studies or meta-analysis. This is a meta-analysis of 18 studies, 143 patients treated with BEV and 148 treated with LITT. And there are selection biases to these retrospective and meta-analysis studies, but I think this is valuable data to review. So in these studies, LITT was equally effective in symptomatic improvement, steroid cessation, and immediate lesion control when compared to BEV. And you see that here. At 6 months, the rate of regression was higher in the BEV group. BEV's going to make the scan look better. Stable disease was higher in the LITT group, that kind of scarring down that occurs after LITT therapy. Very interestingly, survival at 18 months was higher in the LITT group. And I'll show you that briefly here in this table, and you can sort of walk past these initial rows, which shows the radiographic improvement in the BEV group, the stable disease in the LITT group. But importantly, survival at 18 months, 46% of patients who received LITT were alive at 18 months compared to 25% in the BEV-only group. And I think part of that could be selection bias in a retrospective kind of meta-analysis. But there's a piece of this that makes you wonder whether LITT is resulting in more longer-term and durable responses in these patients. A second, smaller study that supports the same findings from the meta-analysis is a small study looking at 25 patients, a retrospective study, 25 patients treated with LITT, 13 with BEV for biopsy-confirmed radiation necrosis. And again, the LITT cohort showed longer median survival, 24 compared to 15 months in the LITT group, and a trend towards higher progression-free survival. So there's certainly some limitations to these retrospective data. Dr. Fecci will walk you through some prospective data from a study that is ongoing, but starts to I think, invite the question of how we include LITT in the treatment options for radiation necrosis and the potential benefit for patients, not just in terms of weaning steroids, but in terms of overall survival. So in conclusion from this part, brain metastasis patients with radiographic progression post-LITT are a diagnostic challenge, and one, we need tissue often to confirm whether there's either progressive tumor or radiation necrosis, and LITT offers the opportunity to do that. Biopsy plays an important role in avoiding misdiagnosis. Less burdensome, LITT decreases steroid independence, and I think is an important consideration in these patients.
Well, anyway, again, I'm Peter Fecci. Thank you. I'm obviously a consultant for Monteris. Okay, so this actually drives home the point that I think I was just trying to make, which is this is not this is an alternative to craniotomy. This is a surgeon's tool for affecting cytoreduction. It is not an alternative to radiation therapy. It is an adjunct, a surgical adjunct. And so wherever in my algorithm resection fit, now LITT fits in its stead when we're doing this procedure. And as a plug for what we were just talking about, the strongest programs really do represent a collaboration between all parties involved: medical oncology, neurosurgery, radiation oncology, neuro-oncology, et cetera. So we've talked a little bit about the LITT fit. I think this fits very well in areas where resection is not a gold standard. So where some of those places are recurrent tumors, radiation necrosis, difficult to access lesions. I've certainly done my fair share of small gliomas in the thalamus. Hypothalamic hamartomas are actually a great use for this. We've essentially cured kids with gelastic seizures doing this and not had to tear apart their head to get to the hypothalamus. So when it's tough to get to those areas with a craniotomy, LITT's fantastic. And generally, if you can get a biopsy needle down there, I mean, logic has it that you can get a laser fiber down that same trajectory. So if you can biopsy, you can often frequently do this. And when we look at things like the initial Stoop data, if patients are only biopsied, they receive no benefit from Stoop. So you really do owe it to folks to affect a cytoreduction for them. And so how common is biopsy only for a relatively reasonably sized lesion in your practice? This at least provides those people some surgical cytoreduction, then for combination with standard of care. And I think to Dr. Groot's point from their study, I think this again drives home the point. This is an alternative to craniotomy. So you would always give chemotherapy and radiation to someone who had had a craniotomy for GBM, and the same holds true for LITT, of course. So what are some limitations? I think to provide a balanced thing here, if you want to use only one trajectory, which is in general what I try to do, it's about 3 centimeters, almost all 3 centimeter lesions you'll be able to cover fully, maybe some 3.5-ish or so. Sometimes just a second trajectory is enough to get this little edge to the lesion that might be misshapen or difficult to otherwise cover with a single trajectory. Doing a 5 centimeter tumor next to the thalamus or the brainstem is not a good use of this. There's some questions, what is extent of coverage? What's the target? And ironically, there are some retrospective studies that found very similar retrospective answers to those questions as all of the Nader and I papers, et cetera, for resection, which is that basically if you can get to a point of about 80% or so and beyond, you get some benefit. But I think the answer is the same thing you would say for craniotomy, which is maximal safe resection, maximal safe ablation. The heat is not specific for the tumor, so you have to watch what you're doing. Although I will note that necrotic lesions and often tumors in general do tend to heat faster than normal cortex. And so you will often see that you'll get this kind of false sense of security that the heat is conforming to the lesion when you're doing it, but stick on the gas long enough and that won't be the case. We do cause edema and you do require steroids afterwards for a period of time, typically. We talked a little bit about the rule of V that I've mentioned, the ventricles and vessels and the high specific heat of water. These are all just considerations more than they are contraindications. Superficial lesions, with the titanium bolts, you would typically get some signal dropout as you were scanning, and so your thermography would be a little blacked out in areas, and that would be difficult. You'd have to wait to see the heat on the other side of the blackout area. But what I would say now is that there's a ceramic bolt that I've now used for a superficial lesion once, and that was fantastic. In fact, we had one of the best thermal masks I've seen even for a deep lesion. So that ceramic bolt is definitely a fix to the issues that we've had with superficial lesions. You do have to be comfortable with trajectory planning, but it's essentially the same workflow as a biopsy. We talked about the little cylinder you can add. And of course, there's a learning curve. And I think a lot of the questions here have been really good. And some of those questions, I think people, as you use the technology more, you get more of a gestalt and more of a comfort with thinking about things. Obviously, as with everything in the world, the real problem are neurosurgeons. From a basic perspective, we're like a kid in a candy shop when you give us a new toy. And so when this first came out, people, especially when that toy is a shark with a frickin' laser beam attached to its head, right? So the problem is people were cooking really big, dangerous lesions with this for a while, and they were hurting people. And this is not a toy. It really, and it does cause heat and it can cause swelling. So patient selection is really important here. And when you select the right patients, it's a boon. But if you select the wrong patients, then it's just not the right tool. And to that point, if you have a hammer, not everything is a nail. There are plenty of screws out there. And the fact of the matter is you've got to go into that toolbox and get the right tool. And LITT is not a panacea. It is the right tool in certain instances. And getting comfortable with making those decisions is important if you're going to help folks. So we've started to ask the important questions because we've been doing this for a while, and we have a lot of experience with it. But as we started to do more, then there are a lot of questions about treatment algorithms and the appropriate uses have come up. And one of those is, what's the role for SRS after LITT for recurrent brain metastases? And then we were talking to folks at other institutions who were not doing SRS, repeat SRS after LITT, and that had been our policy. And we really wanted to get at that question retrospectively. And so what did we do? We went back and did a retrospective study looking at patients from multiple institutions, Duke, WashU, Cleveland Clinic, Yale, Minnesota. We ended up, the patients on this study had to be biopsy proven. So if there wasn't a biopsy proof of recurrent metastatic disease, they weren't eligible for the study. We wanted to make sure our diagnoses were correct. And so, even though that these institutions had many more of patients in general, we only had 55 patients that met all of the criteria. And we wanted to understand in those patients that had gotten LITT alone versus LITT plus SRS versus SRS alone, repeat SRS based on biopsy, what were the differences in freedom from local progression and overall survival. And so I should say from a statistical standpoint, it's important to note that death from extracranial disease was not, we had to censor that out, right, because that's not an expected outcome of LITT that you fix their liver mets. So this is freedom from local progression data censored for non-neurological patient death. And what you see here is that the combination of LITT plus SRS is quite additive and synergistic as far as altering freedom from local progression. And I mean, it's dramatically so, right? So I think what's really interesting is if you look at the differences down at the bottom, I know that's probably small print, the median freedom from local progression in the LITT alone group is 7.5 months. Now this is biopsy-proven recurrent metastatic disease, and this is histology agnostic. Repeat SRS alone was 3.7 months, although I'll note, that it was kind of a small group. It was only, I think, 6 patients in that because there were just not a lot of people that had only gotten biopsy and then gotten repeat SRS. And then it was 29.8 months in the LITT plus SRS group. That's pretty dramatic. And then we looked at overall survival just as kind of obviously this wasn't a study really powered to look at survival differences, but despite that, you can see really a nice statistically significant trend towards increased overall survival in the combination group, 12.7 months versus 5.9 and 6.2 months in the other groups. So, I think we're accomplishing the goal of surgery, which is a cytoreduction that merges with standard of care and allows us to treat these tumors appropriately. So, second question was the radiation necrosis question that we obviously have discussed earlier, just a few minutes ago. And I'll just kind of quickly show the same graphs that were shown. But when we looked at freedom from local progression, how effective is LITT for RN? It's very effective. I mean, really, you can see here that we had a median of 13.6 months of freedom from local progression with this, compared to 7 months in the medical management group. And really, 95% of patients got off steroids, and the median time was, about a month or so, compared to much, much, much longer in the medical management group, which of course was mostly steroids. Some important things to know about when you're doing LITT. There's a very stereotyped and very different pattern of radiographic response. And this is, I think a future challenge here will be objectively finding ways to determine responses. And we're starting to do that, and I'll go through it in a second. But initially, like at the 1 to 2 month mark after you've lasered a lesion, you're going to see a slight expansion in the overall volume of that lesion, but the pattern of enhancement will essentially switch to a thin eggshell of enhancement. And then over time, and that time can be very different according to patients and lesions and what have you, you will see then a contraction of that lesion into basically a gliotic scar. That can take many months, or in some cases it can take just a few months, and we've seen the gamut. But that led us to ask the question of, is there a way of objectively saying on an MRI, yes, we've done what we set out to accomplish here. And what we thought, and I'll know that a lot of people are out there doing various studies to look at various ways of interpreting these images using different MRI parameters. We noticed that because there was this difference and shift in the way that the lesion enhanced, and you developed this eggshell of enhancement, that maybe just the volume of the enhancing area would demonstrate the response. So we looked at patients that had progressed versus not progressed after LITT. And actually this one, sorry, I should have had another little graph on here too, but what we were able to show very, very distinctly is that in lesions that were not progressing after LITT, even though there might be a little initial expansion of just the volume of enhancement, not the lesion itself, by about 4 months, universally they've started to really decline, and then they continue to decline after that. And when we looked at our progressing lesions after LITT, and I'm sorry that that's not on here, by about after that 1 to 3 month mark, you continue to see basically a rise in the volume of enhancement. I'm sorry for not having that graph on here. But that difference at that 4 month mark is really what I think helps people to understand that we've gotten a response. So by 4 to 9 months, if you're not, and you're measuring the volume of enhancement and you're not seeing a decline, then something's off. And that's at least one way for now to start understanding objective responses. We are, of course, very interested then in answering some of these questions that we've just presented retrospective data for prospectively. And I think that's going to be the key for really understanding what impact LITT has and where it fits in the management protocols. And right now, we had piloted this in conjunction with Wake Forest and Dr. Strowd's group because we've been talking about this for years, and they had been involved in those conversations as well. And so this is a little bit of a different study design, but the basic gist is the following. So to be enrolled on the study, you have to have a radiographically progressing metastasis. And then what we do is when patients have radiographic progression, we consent them to be on the study, and they understand that which part of the study they're going to be on is going to be determined by a biopsy that they then get in the operating room. And if that biopsy result comes back as progressive disease, then they will get LITT, and they will be randomized to post-LITT observation versus post-LITT SRS. And we used our retrospective data to power the study. If they get radiation necrosis on that biopsy, then they will be randomized right there to either medical management or to LITT. And we'll compare efficacy, and I'll go over the endpoints in a second here. People can, if they fail, so if, for instance, patients fail the LITT alone group in the progressive disease arm, they then, of course, become eligible for having, salvage therapy with IESRS. If they fail medical management, then they can cross over and get LITT. So the way we often pitch this to patients is no one's being denied any treatment here. What this really is it's a timing study, in a manner of speaking, because if you get randomized to if you're on radiation necrosis, you get randomized to medical management. We're basically saying, we think that LITT works quite well for this, but we don't know if the right answer is to go ahead and do this up front for you or let you work on medical management for a while and then reserve LITT for failure. And the same thing with the SRS after LITT. We're saying, well, we're pretty sure SRS is the right answer, but we're not sure that it needs to be done up front versus waiting to see if you fail. And so we want to look at that. And that's how we've been able to very quickly enroll in both institutions. I think we're up to 9 patients between the two of us in just a few months. So that's pretty good enrollment. The goal is to open this up to other centers in the weeks to come or months to come after holidays, and to have as many as 12 centers. We're looking to enroll 154 subjects based on power calculations. In the recurrent tumor cohort, in the kind of post-LIT SRS versus observation, the primary objective is going to be freedom from local progression, and it's actually going to be freedom from local progression and neurological death, or neurological death. And then for the radiation necrosis cohort, the primary objective is going to be time to steroid cessation, so essentially steroid independence. Secondary objectives in each will be overall survival, and then the other important exploratory objectives will be looking at things like cognition, quality of life. The patients undergo a battery of testing like FACT-BR, Hopkins Verbal Learning, et cetera. They get a baseline and we look at changes. It's standard of care follow-up, standard of care imaging, standard of care procedures, so there's no additional risks and no additional costs from this other than really actually the cognitive and quality of life testing. So in any event, we're certainly looking for people to sign on to this, and I know Monteris is performing those recommendations, and so we'd love to have you involved if you're interested. And with that, that concludes the slides. I'm happy to take questions. Yes, sir.